it change. But anything around that much also, if it is showing some other patterns, it would also mean that. But then the maps have to be good. And of course, there are a lot of screening systems. It's available with all the topographers have their own keratoconus screening system, which can be used to identify keratoconus, not to define progression, but they are easy to pick up earlier cases. And just a small point before I go into the procedure and the riboflavin is like, if you look at this map, this is actually a pachymetry map which shows a thinning in the center, which is central, and this is the anterior curvature, and these are the anterior elevation and the posterior elevation. So you can see this kind of a localized pattern. It's not a smooth pattern. So in such cases again, I think it would be important because this is the optical zone. So the softwares, sometimes if there is a flattening and there is a steepening, it enhances it is not able to process, it enhances, so it makes it look more red. But this is not actually ectasia. And you can look at the Pachy. The Pachy map here is useful because you can actually see whether there is any actual thinning or not. So that way it is useful. So just a point to avoid over-treating.
Can you go to the previous one? So that, no, there is no any elevation at the area of thinning in the posterior floor, no?
Yeah, there is no elevation. Yeah, that too.
I think it's the wrong first thing. There is no significant elevation in the posterior floor. What is the elevation in the center?
There is no elevation in the posterior floor.
Yeah, how much is the elevation?
In that point of ectasia, it shows as minus 49, so it's not even a plus.
Do you consider it as formed first thing?
No, this is a post discuss later. Now quickly, I think I'll go ahead with the. So before, you want me to cover the riboflavin? Yes. So just briefly, just 2 slides on the riboflavin, because Dr. Anand will be going into describing the procedure, how to do it, what to use. So basically, cross-linking has become very confusing as the time has gone. It's got more complicated, because earlier it was simpler. There was only one riboflavin and one kind of a machine and one kind of energy. But now we have, the original one was riboflavin with dextran in it, and now we have one which is hypotonic, and then there is transepithelial. So these are the 3 kinds of riboflavin. We'll be discussing which one to use when, or how it can be used for the best results for your patients. But basically, just before we go in for that, is that this is a slide from Professor Edelhauser, who had done a control studies. So this is a control on the top in which they have not put anything. This is a patient in which they put riboflavin and did UVA without removing the epithelium. So you can see nothing goes inside. There's nothing. And here they have removed the epithelium and you can not done the UV radiation. So they can see a good amount of penetration of riboflavin inside. And here you can see there is slight compaction of the fibers. There is a change because they have done the UV. So basically we understand that epithelium off is the best way to put in riboflavin and do the cross-linking, but it has its pros and cons either, which we'll be discussing. I think I'll hand over to Anand to take over the next.
Any questions? I think it's raw material basis, something like ginger. What is important is that it is sterile. And the manufacturing process is okay, because initially when we were using about 4 or 5 years back, when I started using the Apasami riboflavin, because that time supplies were an issue, it was very, very watery. It used to just flow. I mean, we really didn't know what was going on. And we compared this to the one we were getting from Freshkey, which had a nice viscous flow to it. And we gave them some residual riboflavin from Freshkey, and then they've actually improved it. So the APA riboflavin now is actually quite good. Penetration is good, because initially when it's very watery, I felt it didn't have a holding time on the cornea itself, and we never used to get penetration. So we were really confused of what we were getting. But now I think most of them have sorted out the issues in terms of the quality of the procedure in terms of what is standard, what is accelerated, and something about combination treatments also. I guess keratoconus is similar in terms of treatment. You need to have measurable results, and that is not my photo. Okay. Now there are machines that are available, and you have the Apaswamy, which we've been using for the almost about like 6 years. It's actually very robust. The cost is definitely a factor, and the newer machines now you can actually hike up. The ones that we got initially had an upper limit of 3.1 milliwatts. But the present ones you can actually go for the accelerated high energies of 9, 18, I think even 30 they're planning. You've got Ashi's got used with the Peshki, right?
Yeah, the similar IROC.
IROC, okay. There is also a CCL Vario and there is an intact CXL, which is also quite good. Now, all these, the Peshki I'm told is a standard 30-minute exposure with 3.1 milliwatt. We have the intact CXL, which I'm told can also be hiked up to 45 milliwatts if you want to use it for the LASIK Extra or any of those other mesh. We are quite happy with it. The advantage is now you can adjust the spot size. The older machines didn't have any variation in the spot size, so you came with a standard 8mm spot size. Now with the newer machines, you can have 5mm, 6mm, you can go up to 9mm spot size, which I think is nice. Somebody is also looking at the new machines from Vitro, is looking at optimized beam profiles. The concept of LASIK where the central ablation is more than the peripheral ablation because the way the laser falls on the cornea. Now with the newer machine from Avitro, you can actually have a Topo Link CXL, which is called, they sell it under Avitro 2 right now. So I don't have access to Avitro, but from what I hear in terms of outcomes, there is really no difference. But what is important is you do a check on the output. They have something called a solarimeter. It comes with the machine itself. It tells you how much of output is there, how much of energy output is there from the machine itself. And that solar meter, even if you put it in the sun, you can make out how much UV exposure is there. You put it under the machine and it tells you how much of output is there. You optimize it to 3.1 or 18 or 9 depending on what you're planning. I have used the machine up to 30 milliwatts, and we were finding what we were actually initially confused, because initially when we started, we knew what the procedure, the Dresden protocol, the original Dresden protocol was 3 milliwatts, 30 minutes, and all the published studies have all been with the 3 milliwatts, 30 minutes. The concept of accelerated cross-linking has come in over the last maybe 2 to 3 years. As far as I know, in terms of really accelerated, where you have 3 minutes and 2 minutes, I'm not aware of any published data saying that this is better than the standard Dresden protocol. So we took a compromise somewhere in between. Initially, some of our consultants were using 18 and 30, saying that it was quicker, 3 minutes, 5 minutes, you're out of OT. We've now kind of settled on 9 milliwatts for 10 minutes, which kind of gives it's somewhere midway, and it's like, I guess it's many ways of cooking a cornea. You can microwave it or you can roast it. Now, I feel that if you're a non-vegetarian in terms of using a tandoor, I think the longer you put in, the more effect you get. The chicken gets cooked better. So I felt a longer time is a better time. So I feel somewhere 9 milliwatts, 10 milliwatts is a good balance. In
but what are the studies to sort of support it?
Published, Ritu, I'm not aware. Ashish?
Published, difficult to compare. So I think I myself usually stick to Professor Theo's.
So I think if you go ahead, if you don't even look at the literature, I think it would be safe to not think of going beyond 9 milliwatts as of now till we have further, more people using it, more standardization. So 3 and 9, I think I would still, as Anand suggested, go.
We now got 4-year, 5-year follow-ups, and I think Ashish talked about what you get to see post-op. The amount of longer duration. The effect when you're using a 9 milliwatt shorter exposure is definitely, in terms of reaction on the cornea, is less. Whether the topographic change and stabilization, we're still in early stages. I think it's difficult.
Is there any study where they have compared it in one eye?
Reasonably advanced grade 2 to 3 keratoconus, you would need a secondary procedure, which could be a contact lens, ICL, even an intracorneal ring segment. Now he's mentioned about basically there are two parts. One is the UV source itself, which is actually not very difficult to make. I have a friend of mine who checked up how much it costs to make the UV source. It's about 30,000 rupees, the actual UV source. and the cost of the machine is about 5 lakhs. So in terms of charging, I'm definitely sure that they're overcharging. It's like your dry eye drops, cost about 5 rupees to make, they sell it to you at 50. So it's not a very expensive machine in terms of what you need to put in. The riboflavin drops, there are different percentages, but 0.1% is the most standard one used, so we'll stick to that at least for the procedure. You have basically it's a photosensitizer. It prevents UV-induced collateral damage in terms of penetration. So that's what it uses. I guess epi-on, epi-off difference. Ashish showed a lovely slide. Basically, important to know that haze is an indicator for cross-linking. So you want to see haze in the early post-op period. If you're not seeing haze, you're never sure what's happening. Because you are inducing a reaction, you are killing keratocytes, and then there is a stromal inflammation, there is repopulation. So it's a process which takes about 3 to 6 months, but you would expect to see some haze post-op. Epithelium on, at least in terms of haze, there is almost very mild haze. I haven't done epi on much. I think Ashish has experience with epi on. Do you get haze?
No, actually, with our limited experience which we did 2 years back, I think the haze component is very less, and if it's there, it's very superficial. So what we see normally after epithelium off, you can't see anything actually, clinically. And I think there has been some correlation. Some people have done confocal studies as well to show whether there are changes which occur, and then they don't seem to occur as much or not at all.
So the only way to know whether it's working is to see whether it progresses or not.
That's what
correct. Follow up with regular topos. So, and that's what I think. Jury's still out in terms of outcome. This is a good study, and this is something. Now, when you look at this epithelium on this epithelium, you can make out the difference in compaction of stroma. So, as of now, at ours, we have good experience. We've done about 3,000 odd over the last for 6 years. We take the epithelium off. That is the present protocol in all patients in terms of treating. Whether you should do epithelium on, is there indications? I think Ashish will go through it, but definitely in pediatric patients, if you have an epithelium on, it definitely makes life easier. If you're doing it for younger patients, 12, 13, we do have patients who do undergo cross-linking at that age. Basically check the output, I mentioned that, and remove the epithelium at least 7 to 8 millimeters, because that is where the area of the ectasia is, usually inferotemporal in most people. Now, there is a toss-up between when you use it for PMCD. PMCD is a peripheral ectasia. In terms of results for peripheral marginal conic degeneration, pellucid marginal conic degeneration is actually not good. So, in very limited case subsets that people have published, the results for PMCD are very equivocal. You may or may not get, but I feel this may not be an ideal indication, because one, it's peripheral, you're closer to the limbus, and the band of thinning is limbus to limbus. So you need to actually treat that much of area. So it's not an ideal indication.
What are the methods of removing the preferred methods?
For normal patients, I use a normal number 15 blade and do it on the slit lamp. Carefully make sure that you don't go beyond the Bowman's. I think that's the important part. If you touch the Bowman's with the tip of the blade, you're going to have a scar full stop. You can use alcohol. It's probably the easiest, but you have to take the patient, make them lie down. It's slightly more tedious, but it's in terms of surgical technique, it's cleaner. You get a perfect cleavage. You can use an Amoyle's brush, basically, which you use for PRK. It's a brush, almost like a brush, rotating brush. You keep it on the epithelium, you can get 6 millimeter perfect removal of the epithelium. So these are 3 common methods.
Efficacy-wise, which is better? Efficacy-wise?
I don't think there is a difference.
I think whatever works for you. I think alcohol is one way to do it. We use an alcohol sponge refined at 9 mm and put it for 7 to 8 seconds. But then again, because these are conical corneas, you need to press it. Otherwise, you might have alcohol more in the center and less in the periphery. So over a period of time, I think what I have changed to is we put a lot of paracaine prior to the procedure, which in all these patients usually makes it the epithelium becomes pretty easy to remove, and you can remove it with the help of a hawking knife or a 15 number blade atraumatically. That's a third kind of technique, epithelial disruption. I think that's another way of.
It's basically a cross.
There's neither epithelium off nor epithelium on. In that they are removing, basically you are removing, epithelium is sort of getting removed in certain areas. It's like a network or a grid.
Mesh kind
of a thing. So that's a third kind of way of doing cross-linking, which we are not actually discussing in this particular thing.
20 minutes, if you take the patient to the slit lamp, you will have penetration in the stroma. You can look for an antechamber flare. That was classically derived. Look for antechamber flare before you take it up. But for a patient with normal thickness, 460, 470 kind of thickness, deep stromal penetration is usually enough if you're looking, once you start putting eye drops on the patient on the table before you start collagen cross-linking, you'll get more penetration anyway. So deep stromal for at least starting the procedure is enough. 20 minutes usually more than enough. 30 minutes if you want to be safe and follow the classical procedure. Central thickness, I think what is important with epithelium of 400 microns. So ideally, do a pachymetry before you start. Even if you got a very good pachy on pentacam or an op-scan or an ultrasound pachy, I would advise you, just like you do it we used to do it for PRKs and LASIK and LB Prasad, do a intra-op pachy and make sure that you have the 400 microns. I actually prefer 425, 430 just to be safe. And I'll tell you why. I got some pictures from Dr. Fogler. UVA 365 nanometers, 30 milliliters. And riboflavin every 5 minutes. The dose is of course 3 milliwatts per square centimeter. That works out about 5.4 millijoules. And you put a bandage contact lens. Some people patch at the end. Put a drop of antibiotic, just like your PRK LASIK put a people. Basically, why 365? Because that's the absorption peak for riboflavin, and that the maximum absorption takes place. Concentration 0.1%, and you're basically looking at about 95% absorption at this level. I mentioned UV diodes, 370 microns, and 30 minutes is the minimum what they found, at least in lab studies. That's how they came to this figure. I think Ashley mentioned that old paper which they looked at different times in terms of penetration. What happens in terms of the keratometry values? The published studies in terms of amount of change is hardly about 1.5 to 2 diopters. That's what you would see. You will not see a dramatic change unless you get a scar. In event that you have deep stromal scarring or anterior stromal scarring, there would be significant flattening, but that is very unusual. Ideally, you would get a very mild change, sometimes no change at all on topography or op-scan. This was something that we did. This was our results. We presented this at the Asia Cornea Society. In terms of visual results, it's probably more dramatic. But in terms of keratometry, there's really not much. You would maybe get a mild change in the maximum K. Minimum K doesn't change very much. Average K tends to reduce because the maximum K also drops. So if you look at the follow-ups, if you have follow-ups, it actually sometimes goes up, sometimes goes down because it's not a perfect number that you can get. But if you're getting a haze, you're getting changes in the stroma. Ashi's got some nice pictures of what you see post-op on the OCT. But in terms of keratometric changes, not very lot unless you get a scar or you've combined the procedure, then you get more dramatic changes. This is what I was mentioning about why you need to check the pachymetry before you start. Now this is 17-year-old patient with moderate keratoconus, corneal thickness 410 and minimal thickness of 399. Okay. Now once you remove the epithelium or a partial epithelial debridement, and then you put eye drops of riboflavin, the epithelium, the thickness drops 332. So there is desiccation. The cornea loses hydration, and then that's the reason I prefer sometimes for slightly thinner corneas, if you're looking at 325, put distilled water. I prefer distilled water. You can put hypertonic riboflavin also. That is one option to increase the thickness. So once you remove the epithelium, put alternate distilled water with riboflavin to get your 425, 430 before you start the collagen cross-linking. And during the procedure, if you're doing accelerated or the standard, keep putting the distilled water or the riboflavin so that, along with the riboflavin, so that the thickness is maintained. Because even if you stop putting distilled water, it then again thins out. So
how frequently you do it?
Every 2 minutes. So 2 minutes riboflavin and then 2 minutes distilled water, alternate.
See, I have like what you're talking about, increasing the thickness. That's only with water.
Or you can use hypertonic riboflavin.
But the stromal swelling is because of the water there.
Correct.
Is
Samrat. What I do prefer to do is to make sure that the riboflavin is penetrated. So remove the epithelium, put the riboflavin first, get deep stromal penetration. Start with the distilled water after that. So you got a cornea full of riboflavin and then you hydrate it. So then you get the thickness and you got the safety also. Okay. Hypertonic riboflavin, there are different methods of doing. We had a discussion on the cornea interest group. What different people do is you remove the epithelium, start with hypertonic riboflavin, but the consistency of hypertonic riboflavin is different from a standard dextran-based riboflavin. So that will tend to flow and the volumes are less. This is also slightly more expensive. So you put hypertonic riboflavin first, get the penetration along with swelling, and during the treatment you can use a standard riboflavin alternated with hypertonic riboflavin. That will maintain the thickness and also give you penetration. So or 2 minutes on.
I think what Anand, there are so many protocols and there would be variations which might be very. He's nicely titrating it by measuring it intraoperatively, putting in riboflavin, putting in distilled water, so he's maintaining the thickness. So that is what is, I think, we are trying to reach, we need to do. And one more point was that when we use dextran along with it, when you put riboflavin over the cornea, it adds another 72 microns of thickness. So it adds that 72 depth. So even if you have a, let's say 290 micron cornea after doing the riboflavin and it's become very compact. So when you add riboflavin consistently, it adds another 72 microns, which adds to the safety. So that is the problem, but that is not consistent because you're putting it every 5 minutes. So it stays there, then it dries away, it stays there, then it dries away. And that also probably leads to the variation in results everybody has, what we are seeing. So it's not very consistent, the whole procedure. But as you go along, you can just keep checking the packy, keep putting. So with time, you know that this is what you need to do. You need at least 350 microns when you start the cross-linking, the UV light.
So what kind of packy are you actually doing for the hypertonic or distilled water? At what threshold?
See, there would be a difference in measurement of an off-scan and a pentacam. 350 on an pentacam and 325 on an off-scan. Definitely.
So, but I think we're talking about the thickness, no? Usually the efficacy doesn't change, only the damage to the endothelium varies, no? What
Actually, there are,
blood has to do will do.
yeah,
Only
there are
the
two.
difference, shorter cornea, thinner cornea, and the endothelial problem will be there.
That's what.
Then if it goes deeper, it will penetrate deeper and can cause a scar or it can damage the endothelium.
Efficacy. Strengthening of cornea.
Efficacy would be there, but then it would be compromised with a scar or damage to the end. It would be more efficacious, yeah.
We have patients who undergone cross-linking and have endothelial level scars. That means the UVX is damaged and burns the endothelium. So I think safety is extremely important because all of them are very young patients, second, third decade, they got like 40, 50 years to live. So I think that's important. Safety is what we're trying to stress. And post UVA exposure, it actually drops. So this is serial OCT. So you and this is the reason I prefer to put distilled water during the procedure because 272 you're already in the danger zone. On day one, once the epithelium grows back, this mild edema, you get the thickness back. So during the procedure, I think you definitely do require something to maintain. If you've done an intra-pachy, ideal. Initially, we were doing pachy at 0, 15, and 30, and we were finding the drop to be about 20%. And that's the reason we added distilled water during the procedure. Okay, that's part in terms of technique. The second part is in terms of combination treatments. Any questions on technique?
At the end of the procedure, you wash out the cornea or just put a BC?
I would wash, but with you don't want to wash all the riboflavin. That's not possible. But definitely wash with about 10 ml and put a BCL.
I do put a BCL, put a drop of couple of.
Yeah, put an antibiotic at the end. I think different people have different protocols. We use the protocol which we use for PRK. That is, we give them pain management. We do give them mild antibiotic, steroid, preferably separate. I usually don't use combinations, but a combination of loteprednol with Vigamox or a Catafloxacin, any brand.
Is it preservative free? Yes.
Preservative free, that would be better, yeah. Along with lubricants. I think lubrication is important because it helps the epithelium to grow under. Ashish, you patch, right?
Yeah, in our practice, we do not use the BCL. as you're saying, after the procedure, we wash off the riboflavin, put an antibiotic ointment, and patch the eye for a day. Remove the patch the next day, and along with it, the pain management, we give any analgesics or tramadol, other things. Because in our experience, at least the steep corneas, the advanced keratoconus, we used to get a call every night from the patient, and they used to come. We had to remove the BCL, and then they will be more comfortable because probably the corneas are steeper, the BCL doesn't fit very well, or some other problems. So since then we have abandoned the BCL, and it works fine. And as regarding the post-op medications, what I do is the epithelium off. We also start antibiotics, lubricants, but the steroids we tend to start after the epithelium has healed on the third or fourth day, because to avoid any chance of non-healing. Usually the young patient, it heals pretty fast, but that's just a protocol change that we have. We start on the third day, but one can start the same day.
How long do you continue the steroid and NSAIDs? Do you use NSAIDs?
No, we don't use any NSAIDs. Okay. We only use FML or Lotepred for 15 days.
Okay.
And antibiotic as well.
Okay. So after that, you maintain them on anything in terms of?
Only lubricants for a month or so. And if they have any concurrent allergies, of course, then we might continue steroids longer or any mast cell stabilizers.
I think that would be what
I have seen in PRK is immediately after doing a PRK, I used to put the ice pack outside.
Sure. But I think important is that when you're doing a PRK, so in this, that exposure is minimal. So pain is definitely less than a PRK patient.
What do you do?
The PRK is done first, and then the CXL is done. That is the classically described Ethan's protocol. So you treat 70% of the sphere in the cylinder, and you do ablation about 50 to 70 microns. Suitable only for early keratoconus. I think that's to be emphasized. I'll just go through one of our case presentations. This patient actually underwent cataract for defective vision, but the referring doctor actually forgot it. And we plan to do a TopoLink PRK combined with CXL. Now, of course, there is an option in the Wavelight platform or the Zeiss platform or the Schwind where you can actually ablate the steepest part of the cone if you got enough thickness, and it matches that. So it's a slightly different ablation pattern to a normal LASIK. So when you combine PRK with CXL, you're trying to treat the irregular part of the cornea, make it more spherical. So the steeper part, if you is treated first. Now, this is a pre-op picture, the pentacam. So you can make out this is the steeper part, and what you do with the TopoLink PRK, you treat the steeper part first. So that's how it is done, and you can make out that this is the early eye trace. You can make out the images definitely become better. It's a lot more regular. You can actually wear a glass now, and over a period of time, and this is with ray trace, you can actually see the improvement in vision. So it does definitely make a difference. Now, in terms of CXL PRK, what is important is you're not trying to correct all of this refraction. So even if it's early keratoconus, you might have maybe -2 with -2 SID, you would not treat all of it. You would try and optimize the treatment. The ablation part would be recommended by the computer, and the balance you can add in maybe 1 diopter, 2 diopters, because the normalization of the cornea when you're doing a TopoLink PRK is almost 30 to 40 microns on average. On top of this, you add another diopter if you want to treat the irregular astigmatism. So that is the amount of correction that you would get. You would not get them glass-free. You do the treatment first, and then at a later stage you put in the collagen processing. So anyway, the epithelium is removed. So the procedure for the CXL after PRK is similar. It will still take you 30 minutes or 10 minutes after you do it. The Intax is basically 2 pieces of plastic which are put in the mid-stromal, the peripheral stroma, and they charge you about 45,000 for this. Our results have been reasonable for 6 months to a year follow-up. All of them have an improvement in the uncorrected and the miscorrected vision. So in terms of vision, yes. This is one topography patient with a slightly irregular cornea. So the cone is decentered. So there's protocols, we won't go into that because this course doesn't deal with the Intax part. But here we put an irregular, slightly asymmetric cone. So thicker ring inferiorly push the cone central and a superior cone, superior ring. And you can make out the difference. This is after treatment. This is at presentation. This is about a 6-month post-op. So it does flatten. Steeper the cornea, the flatter it becomes. And if you see the intraoperative photograph, you can see that it flattens it quite nicely. Intraoperatively, you can actually make out the flattening. This is one of our younger patients, and if you're using a laser and combining with CXL, what is important is you can get very, very good placements. So intact's also very similar. Do the procedure first and then do the cross-linking. In this, the advantage of a smaller spot size becomes, because this is put at 6mm zone, and if you have a machine that can reduce the spot size to 6mm, you can do the collagen cross-linking only in the central part, do the packing of course. So the procedure for the CXL, when you're combining it with treatments, is not very, very different. This is one other of our patients. He's followed up for almost 8 years now. He's also doing well. I think ICLs I will skip in want of time, but just to mention that it's done at a secondary procedure, usually about 6 to 12 months after the collagen cross-linking before you plan to do an ICL, because that is the effect that usually does take place. And what we found in our study was that a lot of them actually end up with a bit of hyperopia. That is because the collagen cross-linking effect is not a single-time effect, unlike an ICL. That's a refractive change. So, if you're planning to do an ICL, aim for a bit of myopia, preferably half to 0.75 diopters, because the collagen cross-linking effect continues. It is not a one-time effect. We've seen follow-ups of 2 to 3 years where the flattening is very gradual, 0.2 every 3 to 4 months. So, if you plan to do an ICL, aim for a bit of myopia.
It was conceptualized to be a procedure to stop the progression of keratoconus. But because of some flattening seen post-operatively and some visual changes because of that, it's now looked upon as a refractive procedure. So all the other procedures would be very useful to improve the unaided vision. But I think progression is the first thing that we are trying to stop. This is something, I just wanted to show you a video how to remove the epithelium. There was a question. So this is the way in which you refine the alcohol sponge which is available from BD, which is used for the IV injections. So you just refine 9 or 8 mm, put it on the cornea. So that epithelium becomes easy to remove, and one can remove it with a sponge or anything. So this is also one of the atraumatic ways. But important to notice that this alcohol is almost 70% isopropyl alcohol. It's not 20% as is recommended to use. So this should be used for a lesser period. So normally we use it for 5 to 7 seconds only. And just a few slides I wanted to show and discuss what to expect the first post-operative day with the epithelium off cross-linking. This is what we should be seeing. One on the slide on the left is what we see. There's a lot of haze, a lot of prominence of these stromal fibers. So this is ideal. This is what we should see. It might vary from patient to patient because there is a variation from keratoconus to keratoconus how it happens. And this is a little later on, although this is a little more enhanced in this photograph, it's not as much, but if you diffuse the light, you can see it in that way. Later on, it goes down to much lesser. As time goes, it becomes less and less the haze. But you might still be able to appreciate some striae, some prominence of the posterior stromal fibers is what it is described as. And these sometimes might be concentric around the cone. They might go concentric around the cone. This is something, what I'm telling you is something that we see and which other colleagues also see, because some of it has not been described or published in literature as such, but this is what we normally see. So this is a normal haze in one of our patients after cross-linking, and this is a published photograph from Professor Kanalupos in which, although he had combined it with a PRK, so you can see this is a patient from India, this is a patient from Greece. It looks pretty similar. So this is just to give an idea that it looks it should be similar all around the world as well. There might be individual variations based on the races, we don't know. And this is one thing which has been described as the demarcation line. This is again, which probably depicts the edge, the end of the cross-linking effect, because it shouldn't go beyond to the endothelium. So this is ideal. You can see a haze which goes almost 2/3 the depth. This has been described by Professor Theo Seiler. And you can see the important thing here to note is that because of the cosine effect, as has been mentioned by Dr. Anand, it is thinner in the periphery because the cornea Central, it will penetrate more. Periphery, it will be lesser because of the curvature, because the light source has to go in a slanting way. Similar to what we have in the excimer lasers, in which when they realized that this is happening and they incorporated more peripheral pulses to make it smoother in the periphery. So this is a similar thing which we see in cross-linking. It is shallower in the periphery, it is deeper in the center. We don't know what is the clinical impact of it, although there are new models like the Evetro and even the AIOC in which they have changed the lens in such a way that it becomes aspheric, so it should be deeper in the periphery as well. So conceptually it makes sense that it should be homogeneous all around. But then again the problem is the steepness of the cornea. You have a 46 cornea, you have a 56 cornea, the steepness is different, so we don't know whether that will be perfect. That is the answer for all the corneas. But this is what.
How deep should be the haze? I mean, when you're seeing it.
So this is what I'm coming to. If you see this patient, you can see this is a OCT. Just because on the slit lamp you can only see so much. So this is, I would say, a perfect haze. It goes right up to the predecimal, a little above the predecimal, leaving around 15 microns or so. So this would be ideal for me if it goes up to that level. If it goes beyond, probably I have penetrated a little more, because this is what we see after a few weeks. So we don't know actually how much of it goes behind. And this is, again, as you can see in this patient, you can actually see it is a little shallower here. It is not as deep as you can see, and it is a little variable also. If you see, the cornea is irregular, and accordingly this also varies. So it's not that it will be consistent, it will vary on the curvature of the cornea. The other thing which I'll be discussing about later is that you can see this part, this reflectivity is the epithelium of the cornea. The epithelium in keratoconus patients is also of variable thickness, it's not homogeneous. So that also has an impact on the depth, the penetration, depending on if you have done an epithelium on or other things. And this is a normal haze which has been correlated with the confocal. And just a passing mention, as Anand had also mentioned, if you make crisscross, if you are doing a crisscross pattern as was shown in Dr. Fogler's photograph of removing the epithelium, if you go a little more deeper, you might actually rupture the desmids, and then it would leave scars behind, which might have an impact. So you need to be very careful that you don't use a sharp instrument. It should be a blunt instrument if you're trying to use that technique of debriding the epithelium. And this is another patient that we had come across in which he had linear scars like this, post-cross-linking. So we suspect, sometimes I was discussing this with Anand and he was mentioning maybe the doctor might have tried to remove the epithelium on the slit lamp. And sometimes the angulation of the fitting of the blade might have gone slightly diagonal, and that might have caused a rupture of the bones. So I personally, in my technique, we do the whole procedure in the OT. So in the lying down position, as we are used to with the PRK to remove the epithelium. So it's up to you, whatever way fits into your schedule in your clinic. So you can choose to do this. But these are things which can happen and which can be avoided easily. And just to show you, and these are the earlier cases in which when we didn't have access to the pentacam or the cirrus and we relied on the ultrasound pachymetry, 2 of our patients developed deep stromal scars. Like this. This is because the actual thickness of the cone, the central, was more, as I was mentioning. So you really, I think after these 2 patients, we really make sure that we always have the pentacam or the cirrus map to know the exact thickness. And if we don't, then we should compensate in such a way that you make it a lot more safer by using the still water, so that the thickness is always 30 microns. This is the same. This is an OCT just to show you a comparative, that this is a demarcation line which you might see. It is more homogeneous, it is more consistent, it is more linear and at a certain depth. If it is patchy at certain places, then it's more like a scar. And this is the demarcation line described elsewhere and published. So this is just to show you that. And now when you're looking at haze, sometimes it's difficult to understand what to expect. So this is just a photograph of the PRK haze. Post-PRK haze is a lot more reticular. I think you might have seen, this is not what it looks like, the post-CXL haze. This is a lot more different, it's a lot more deeper. And this is another thing which sometimes we see immediate post-op. You can see there is an epithelial defect. This is the first post-op day. And you can see there is a haze and there are certain prominence of the posterior fibers. You can see some linear lines over there. So this is something that you would expect to see the first post-op day. Same photograph, similar. So this even these are not Vogue striae, but this is prominence of the posterior. This is what becomes later on. If you have Vogue striae, they also become more prominent immediately on the first post-op day, and then they level out. This is a 3-week post-op photograph of the same patient, and then they level out. Then you stop seeing those prominence over there. This is another patient with a similar. In this, you can see it is a lot more non-homogeneous. Sometimes there is a variation that the striae are off-center. They are only at one place. They are more focused, like in this case. So this also does something that we see often, and this is something that forms a part of the variability of the procedure, the variability of the corneas. So this is also something that you might see. And just a few more photos just to see the demarcation line. I think, is it clear that the demarcation line, I think you have got an idea what does it look like. So this is again the same patient, the right eye which has not been operated on. This is the post CXL. After 1 month you can see the haze, you can see the demarcation line. So when I see such a patient after cross-linking, the first post-op day I see those prominence of striae, and I see after a month, then I know that there is something which has occurred. We have done cross-linking and there has been something. There are patients in which this thing is not as much visible or is not homogeneous. So these are patients in which we always have a query whether the cross-linking process as has been described has occurred or not. So this is, if you see this, then I am also satisfied that we have done the cross-linking and it's there. So these are just the clinical pictures to keep in mind, and these are the OCTs of the similar patients, and so you see a lot of variations, similar. As you can see the haze, you can see the demarcation line. This is another patient with a similar pattern.
How long does it take for the haze to clear?
The haze to clear? I mean, there would be some haze which would gradually, I think after a period of 6 months to a year, sometimes you don't actually see anything. Except if you still see, I personally feel that if you still see after 6 months to a year, you see some, that means it's not haze, that means there has been a slightly over cross-linking. It's kind of a, I would say, a kind of a controlled scarring in a way which probably we are causing over there.
I think we are in the last 2 minutes. I think the next session needs to start. So we'll just take the questions outside. Is there anything else, Ashish, you want to cover?
Can you just...
From Professor Dr. Michael Law in Malaysia. As you can see, this is immediate first post-op day. And this is edema. I mean, there is actually an increase in the thickness of the cornea. So this is edema. That means you have done sort of a damage to the endothelium, and this will clear up with steroids pretty fast. This won't. So this is a photograph in which he had done a bilateral cross-linking, and one eye was thinner than the other, which had more edema than the other, and both cleared up eventually.
Do you use some cortisone drops or something like that to reduce it in post-operative if it remains for a longer time, 2-3 months?
No, I mean, if it is 2-3 months, then it's not edema, then it's haze.
That's what I'm saying.
Then, I mean, you can use steroids in the initial, which we are already using, to prevent the inflammatory process to cause more scarring. But I think, I don't know how much role would the medicines as such play.
So what does the edema mean? That means there's been damage to the endothelium.
Damage to the endothelium, yeah. It's also, some people refer to as a term called endothelial infarction.
See,
that it's not actually damaging it, it's causing
a... 2 weeks the patient was okay, and then presented with edema.
That's unusual, but then also it's an indication that you do have some...
It did clear up with...
Just mentioned one thing is the sterile infiltrates which have been reported. That you see this kind of picture in which there will be infiltrates diffuse sometimes like this. So these have been reported after cross-linking, and they usually respond to steroids and they clear up. This is another case of a similar picture which has been published on the cornea discussion group. This is believed to be because of some interaction with the contact lens rather than the cross-linking procedure per se. Because in our practice we don't use the contact lens, and since last 2007 I have not seen a single case of such an infiltrate post-cross-linking. So I don't know, in your practice, have you seen any sterile infiltrates?
Sterile infiltrates, no, but if I see something like this, at least in India, I would actually treat it as infection. Because my worry would be infection first.
You need to rule out, yes, but this is something which has been...
Just those for typical basic like infection that or TV or
how much gap would you do, or do you do?
single sitting, but I would prefer not to because if you're patching, it's probably very difficult. But a 2-day gap for the epithelium to heal, remove the BCL, then go with the other eye 2 days later. So, or a 1-day gap. I don't think there's any protocol in terms of that.
Yeah, no, I mean, I'm very conservative. We keep a gap of at least a week before we do the other eye. Once the epithelium is healed and the patient is okay, because the haze sometimes is very disturbing. So
because they're younger patients who are actually, I mean, you know, if they're, you do the worst eye first, so they're okay with that. But then because of the haze, sometimes they're not keen on doing the other eye.
true.
Because they're actively working and they can't function without that.
So that is the challenge actually. That's why the epithelium on is so popular, because it doesn't cause any problem to the patient. There's no haze, everything is fine. But then again, it's not as efficacious, I think. And just wanted to show you a few. There are infections which have been reported like in any procedure, not due to cross-linking. There's been fungal infections, there's been infectious keratitis, there's been streptococcus, and herpes as well. So these are just things which have been reported.
I am Professor V.P. Gupta from Delhi. We have our co-chairman Dr. Acha Rajani on my left. We have Dr. Rath with us, who is convener, and Dr. Roshmi Gupta as moderator. So I would like to know whether the presenters are there or not. How many? So I invite, without wasting time, the first paper, that is the surgical modification in evisceration and enucleation with intraorbital implants, a 10-year evaluation. The presenting author is Dr. Shantanu Mitra. Dr. Shantanu Mitra, please.
Morning, everybody. I'll be talking about surgical modifications in evisceration and enucleation with intraorbital implants, a 10-year evaluation. I do not have any financial interest to disclose. Without intraorbital implantation, evisceration and enucleation patients face the problem of post-enucleation pocket syndrome, where a redistribution of orbital fat occurs from superior to the inferior and anterior aspect, thereby causing an abnormal tilt of the artificial eye. Current status of intraorbital implants are non-porous and porous. The non-porous are inexpensive and easy to handle, as there is no tissue integration or no direct coupling with the prosthesis. The purpose of this study was to evaluate the outcomes of using non-porous and porous orbital implants for anophthalmic socket reconstruction following enucleation and evisceration. It's a retrospective, non-comparative interventional case series where spherical acrylic as non-porous and synthetic ceramic as porous models were used between 2001 and 2011. Follow-up range 2 to 11 years. Total number of patients were 567, where 306 were non-porous and 261 had porous implants. In the non-porous group, evisceration was the more important surgery done than enucleation. The indications were enterostaphyloma, endophthalmitis, prephysical eye and painful blind eye. Complex orbital trauma, tumors and infected cases were excluded. The porous variety used in this series was ingeniously developed in the laboratory from calcium hydroxyapatite powder generated in the laboratory through a wet chemical route, and both conical and spherical designs were used. In the non-porous variety, the evisceration was performed in a standard manner, excepting a double breasting closure of the sclera anteriorly over the implant. In the enucleation variety with the non-porous models, initially the implants were wrapped in donor sclera and the recti muscles were reattached on the sclera. Later on, 47 cases were done with myoconjunctival enucleation, where the recti were reinserted in the conjunctival fornices and the implant was put in the orbital cavity. And tenons and conjunctiva were closed separately. In the porous, with the porous variety, with evisceration, 2 anterior scleral releasing incisions were given 180 degrees apart, and posterior sclerotomies were done around the optic nerve head to open up the scleral cavity posteriorly, so that the conical implant goes inside the retroorbital space without giving much tension to the closure of the sclera anteriorly. And conjunctiva was closed in a separate layer. With the enucleation with the porous variety, Initially, again, the 4 recti muscles were reattached through a prefixed proline suture looped in the drilled models. Later on, this was further modified by putting an anterior scleral cap over the implant, which was taken from the enucleated eye itself, and the recti muscles were reattached on the scleral cap. Tenons and conjunctiva were closed separately. Drilling and pegging to incorporate the intraorbital implant with the prosthesis was done in 33 cases. After excising the conjunctiva and sclera anteriorly, a drill was made with a 18-gauge IV needle and a non-porous ceramic peg was introduced. Back surface of the artificial eye was modified to fit the head of the prosthesis. Ratio of the prosthetic displacement to the normal eye displacement in horizontal and vertical directions were calculated after taking photographs with software in straight gauge, lateral gauges and superior gauge. And pegged prosthetic motility divided by the non-pegged one gives the percentage motility change. Objective assessment of the volume replacement showed that both in non-porous and porous variety, there were good volume replacement in more than 85% of cases. But the implant motility was not totally transferred to the prosthesis until both are coupled through pegging procedure. Without the pegging procedure, the non-porous and the porous showed almost similar movements. Complications were mostly anterior exposure, which required explantations in 9 cases of porous variety and 4 of non-porous variety. And the most common complication associated with peg system was the spontaneous extrusion of the peg. Intraorbital implants provide better cosmesis for anathomic socket reconstruction. Porous implants have some unique advantages, but exposure rates are higher with porous models. Synthetic HAP-based implants are being evaluated all over the world with comparable results. The present porous study material used in this series has already been successfully employed as implants in more stress-bearing areas like hip joint prosthesis and dental implants. But the study has limitations like a non-randomized sample, single surgeon data, non-comparative analysis, and prosthesis coupling done in small percentage of cases. So to conclude, porous and non-porous models give good volume replacement. Coupling with prosthesis is mandatory for maximum movements. Pegging needs further modifications to avoid spontaneous loss. This 10-year study showed good favorable results with the synthetic porous models. Thank you.
Thank you, Doctor.
No, sir. Customized, sir.
All eyes.
All eyes.
Porous and non-porous.
Yes.
Do you attribute any reason for exposure?
Because of the more corrosive, more roughness of the models with the porous material, it causes a tissue dehiscence or tissue disruption.
But that was seen only in some percentage, not in all.
Only in some cases, not in. Because this is better than the natural hydroxyapatite in that way.
Your data, in the sense the extrusion, was it all in the enucleation patients or was there any evisceration patient also? And once you modified your technique, like put a scleral cap, how much was the difference?
Yes, enucleated patients, as you have mentioned.
So you wouldn't be able to give us some numbers for these two categories?
Dr. Mitra, I think studies were done for these synthetic porous materials.
Yes.
So the only question I would have is, after having done that, why did you think of a methodology which would be kind of prospective, comparative, to come out with definitive data?
Yes.
So now that you have this data, what is the next? What are you thinking of going ahead and actually comparing? Like, you've already accepted the limitations, so that there is definitely a search for alternative materials which are economical. So are you thinking of something ahead so that we can come up with a clear answer?
All this animal model data and everything, who is the sponsor and the whole organizer of this evaluation process, I have to put I did the human trial part only, and I have submitted my data to them. I have to go back to them to what you were suggesting. I have to give them that suggestion so that it can be done. Actually, 10-year evaluation study, I have already presented this many times before in AIOC forum also. So I didn't, but I acknowledge at the end I acknowledge the organizations.
You have presented the same paper in AIOC paper?
Not same paper, sir. The porous models,
in treatment. Presenting author is Dr. Sasha Manchani. Dr. Sasha Manchani.
And delegates, I will be speaking on orbital measis presenting in a lady with fungating squamous cell carcinoma. Is there a role for ivermectin? There are no financial interests to disclose. Orbital measis is relatively rare, accounting for around 5% of all cases of measis. It is usually well managed with manual removal of maggots along with the application of betadine, turpentine and paraffin. Ivermectin is a broad-spectrum antiparasitic drug and has been tried with success in a few cases of orbital measis. Here we describe the limitations of conventional treatment and the use of ivermectin in the treatment of orbital measis. An 84-year-old lady presented with a large left-sided orbital mass and the chief complaint of multiple worms crawling out of the mass. At the time of presentation, she was delirious with intense itching and in extreme agony. The relatives reported that the mass had been slowly growing over the past 2.5 years. Over the past 2 weeks, the patient had become very uncomfortable with worms crawling out of the mass. On examination, she was disoriented and hypertensive. Gross examination revealed a 10 by 8 by 6 centimeter fungating mass with inferior extension till the mid-cheek. The surface was irregular, blackish and necrotic and covered with copious greenish discharge. Upon displacement of the mass downwards, the upper eyelid could be partially visualized. However, the lower eyelid and the globe could not be seen due to the large size of the mass as well as the worms crawling out of the orbit. The maggots varied in size from pinhead to 1.5 centimeter. The surrounding skin was erythematous and warm. She had enlarged and firm preauricular and upper cervical lymph nodes. The right eye showed a mature cataract. Examination of the right eye was otherwise normal. A provisional diagnosis of orbital tumor, likely squamous cell carcinoma, complicated by superimposed orbital measis and cellulitis was made. Her laboratory investigations revealed a leukocyte count of 21,000. A sample of the pus was sent for microbiology, which revealed Pseudomonas species. Her immediate treatment included stabilization of fluid and electrolyte status and control of BP. She was also started on intravenous antibiotics. A contrast CT scan of the head and neck revealed a heterogeneously enhancing fungating mass arising from the left orbit, completely surrounding the globe and displacing it forward and laterally. There was orbital fat stranding without bony erosion or intracranial extension. Also noted were enlarged preauricular, parotid and cervical lymph nodes. With the primary aim to relieve the immediate pain due to the maggot infestation, cleaning was done several times a day with turpentine, betadine and hydrogen peroxide, along with manual removal of the maggots and crusts. However, after 2 days of regular cleaning, it was not possible to remove all the maggots due to escape of the worms into the depth of the orbit and the crevices of the mass. The patient at this point was unfit to undergo any surgical procedure such as exenteration. Thus, we decided to give a trial of ivermectin, where 12 milligrams was given orally once a day for 2 days. The evening following the first dose of ivermectin itself, more maggots were emerging to the surface and they were much easier to remove as well. After 2 doses, the orbit was rendered maggot-free. Thus, as you can see in the pre-ivermectin photo, the number of numerous abundant maggots that are seen have disappeared after the use of ivermectin. Further management, once the patient was medically fit, she underwent a subtotal orbital exenteration with primary closure of the wound. Histopathology revealed it to be squamous cell carcinoma and the margins were free of tumor. The patient and the family decided not to pursue further treatment in view of the patient's old age and her desire to return to the village. Ivermectin has been used before to treat orbital myiasis. However, there are few case reports. There are no clinical studies and there is limited clinical experience in its use. We found ivermectin to be of extreme benefit in this patient where maggots were inaccessible. Also, cleaning sessions are extremely unpleasant for doctor and patient alike, and ivermectin appears to decrease the number of sessions required to render the orbit maggot-free. It is an inexpensive drug, around rupees 8 per tablet, and it's a fairly safe drug having minimal side effects. Thus, ivermectin does have some role to play in selected patients of orbital myiasis, and one can explore it as a first-line drug along with manual removal and locally acting agents in view of its efficacy, low cost and high safety profile. Thank you.
Thank you, Dr.
Trying to cover it up with steroids or anything. You had anything in mind?
No, sir. They were all ectoparasites, meaning on the surface, whereas in like in microphile area where the worms are actually deeper, one has more of these toxic reactions. Where ivermectin is also used is in lice and scabies, where one doesn't really see the toxic reaction, probably because the worms are more on the surface. Also, why it's not previously been thought to be efficacious, because one feels that does it really reach the parasite. But recently we have seen a few case reports reporting its benefit, and it probably does have a role to play.
What was the...
Which is 200 micrograms per kg, so it came to around 12 milligrams.
Did you do biopsy before exenteration?
Yes, sir, we did an incisional biopsy. As soon as the mass was clear of the maggots and the pus, we sent an incisional biopsy. It proved to be squamous cell carcinoma, after which we went ahead with the exenteration.
Do you have any video for maggots crawling?
Yes, sir, I actually did, but I don't have it here, unfortunately.
Dr. Mansukani, that's a very innovative approach. We should congratulate you on that. And just a couple of questions. One is, it might have been nice to complete the documentation by getting a microbiology report on some maggots that you removed. It is so fungating. A lot of it is avascular. Obviously, it's outgrown its vascular supply. So how do you think the ivermectin given systemically was reaching that area?
Anterior had outgrown the blood supply, which is why the maggots were not even staying on the surface. They were going much deeper in, and where they were deep inside the orbit and inside the crevices, that's where we couldn't remove them from. So as soon as one shines the light or any kind of activity, they disappeared inside. And even though you cleaned it at that point, in a few hours again they all emerged from the surface from somewhere inside. So probably while the surface and a lot of parts were necrotic, there were also larger areas inside which had good vascular supply where the drug could reach the worm.
Thank you.
Dr. Ekta Agarwal for a presentation on orbital IP4 related diseases.
And is the clinical pathological profile of orbital IgG4 related disease. No financial disclosures. IgG antibodies, these are the antibodies synthesized and secreted by the plasma cells, out of which IgG constitutes the 75% of the bulk, and IgG4 in particular is less than 5% of the whole component of the IgG antibodies, which has a protective role in inflammation and allergies. IgG4 related disease actually is a recently described entity where the composition is either a diffuse or a mass, forming inflammatory reaction in the tissues which are infiltrated with IgG4 positive plasma cells, which may be accompanied with elevated serum IgG4 levels. Out of all the structures affected by this disease in the orbit, lacrimal gland is known to be the commonest. Thus, we aim to evaluate the clinical features and the histopathology and the laboratory findings of the disease and compare them with non-IgG4 group. We retrieved all the 198 patients of orbital lymphoproliferative lesions from January 2008 to December 2012. Patients with specific inflammation and lymphoma was excluded from the study, and we had 46 patients finally with sufficient clinical data and tissue material, and the patients with adequate follow-up. We studied the demographical details and their systemic associations. Imitoxylin and eosin stain sections were studied to evaluate the storiform fibrosis, lymphoid follicles, lymphoplasmacytic infiltrate, obliterative phlebitis, multinucleate giant cells, and eosinophils. Serum IgG4 levels were studied in all our patients. IgG, G4, and CD138 staining was done, and this is a picture showing IgG4 staining. And there are two diagnostic criteria which is very important for this disease. One is more than 10 per high power field of IgG4 positive plasma cells, and the ratio of both IgG4 versus IgG should be more than 40%. And we categorize the patients in two groups. The group 1 with IgG4 where both the criteria were fulfilled, and this statistical analysis was done. When we compared both the groups, we concluded that bilaterality was significantly higher in group with IgG4 disease. This is a patient with a complex clinical presentation with either a lymph swelling or chronic painless proptosis. This is the commonest presentation with the way this disease presents. Studying the clinical features, IgG4 related disease has all the patients where the lacrimal gland was involved. If you see, all 11 patients had this lacrimal gland involvement in group 1, and group with a non-IgG4 had more of a orbital soft tissue involvement, and only 50% of the cases had lacrimal gland involvement. Lymphoid follicles, plasma cell aggregates, and dense fibrosis was significantly higher in IgG4 related group. Studying the lab investigation, serum IgG4 titer was high, that is 8 out of 11 patients had high titers, and just only 3 out of these 11 patients had normal serum IgG4 titer. Thus, it is known in literature also that these patients might have normal serum IgG4 levels, and the patients with non-IgG4 disease might have elevated ones, though the percentage is very low. And it is also mentioned in the literature that in these patients, you can monitor these levels to gauge the treatment, but we did not find so in our study. Glucocorticoids is the standard way of treatment in these patients with 0.6 mg per kg body weight for 2 to 6 weeks and taper gradually. In our study, only 5 patients in IgG4 group had a complete response, and the rest were either partial or refractory. Studying the long-term follow-up, which was a year in all our study patients, none of the patients in IgG4 group had shown a relapse. How should we study about these patients is, why should we do it is, that IgG4 related disease group patients, they closely mimic in their clinical presentation and response to non-specific orbital inflammatory disease, reactive lymphoid hypoplasia, and idiopathic myositis. And we can differentiate these patients based on the detection of IgG4 plasma positive cells. Ocular adnexal lymphoma is a very close mimic, because in the literature it is known that IgG4 patients can eventually evolve into lymphoma. Thus, to conclude, IgG4 related disease presents bilaterally commonly with either an eyelid swelling or a chronic painless proptosis. Lacrimal glands is very commonly involved, and glucocorticoids is the way to go for the treatment, but we need a closer follow-up in these patients because these are either refractory, they might be either refractory to treatment or there is a higher chance of risk of transformation to them. Thank you.
Thank you, Dr.
It may be or it may not be.
Mostly it is a systemic disease and there are several presentations with some ocular involvement. And
right.
Serotumor should be kept in DT.
Kept in as a differential.
So what systemic workup you did in these cases?
These patients have more of systemic association.
Autoimmune pancreatitis and several other retroperitoneal fibrosis, cholangitis, liver, biliary.
Yes.
Almost all organs
all
are involved.
Organs have known to be involved.
So that did you rule out that?
Yes, we did a systemic workup for them, but in our 11 patients, we did not find any known systemic entity in these patients.
All patients who had lymphoproliferative disease. So if you're trying to look at IgG4 on an inclusion criteria, do you think it would have been good to also include all patients who had non-specific orbital inflammation on histopathology and then
we included all the patients who presented with this mimics picture And on pathology, when we found out that there is plasma cell infiltration, more of plasma cell pathological diagnosis, it mimics very closely to radiology and clinically to other features.
The second question is, as far as the diagnostic criteria of IgG4 related disease is concerned, serum IgG4 levels elevated are definitely one of the major criteria. Now,
not for the diagnosis.
Not
for the diagnosis.
Okay.
It's a pure histopathological diagnosis. Serum IgG4 can be raised, as in our 8 out of 11 patients, and the other group with 35 patients, even they had elevated.
Yeah, but the question is, if that is something that you were wanting to look at, how did you? I mean, it was a retrospective study. Patients were from 2008 to 2011. Did you kind of go back and ask them for? And if you did, by that time the serum IgG4 may not be any more elevated.
Correct.
So, what is the significance of serum IgG4?
Serum IgG4 is known to be elevated. Whenever we did the study, not every serum IgG4 was not found to be normalized in all the patients also.
I understand, but the question is in retrospective. By the time you see, that means you're not seeing active disease. By that time you may have treated with steroids. And the serum IgG4 are known to come down with oral steroids, with immunomodulators, with rituximab.
Correct.
Once treatment has been initiated.
That I accept that totally.
Related diseases known to be associated quite a bit with sclerosing inflammation in the orbit. So to refresh my memory, you did mention how many of these patients had a sclerosing pattern?
Out of 11, I think we had 3 patients who had a sclerosing pattern.
That's fine. Secondly, based on this, what would be your recommendation? Because, in the clinics, which are the patients who we would recommend for IgG4 staining and IgG4 serum levels?
Yeah, see, as I mentioned, a patient presents with painless proptosis or a lid swelling, and it's a chronic lesion standing. If patients don't complain of anything else, they're not symptomatic. And then, as we all send all our material for pathology. So it's a pure pathology diagnosis, and then you go ahead with serum IgG4 and follow them closely.
My question is, because obviously it would be sort of not very productive to ask for IgG4 in all patients.
In all the patients, correct. That's
so,
right.
pathologically, what are the criteria from where you go on to ask for IgG4?
Right.
Or where are the cases where the pathologist would recommend that you
number
ask for
one
that
is
stage?
storiform fibrosis with a very typical whorl-like pattern of fibrosis. But if you have a lacrimal gland lesion, this fibrosis might not be present. Dense plasma cell infiltration and lymphoid follicles. These are the key features which a pathologist should think about IgG4 related disease.
So that might be a take home for all of us, that when we are sending our samples for pathology, we can include a note to the pathologist that if you're looking
for
these
these 3 things, correct. Yeah. And if there's a dense lymphoplasmacytic infiltration, then they can go ahead with IgG4 stain.
Thank you, Doctor.
Just one comment to talk about orbital disease and other systems being involved. So that is something definitely should be looked at. But if this is only an isolated orbital IgG4, then that's actually a very large series.
Yeah, it's and other thing I can say, maybe the patients are not aware of the other systemic things present in them, or they're not presented in the system.
Yeah, so very interesting data and good work.
Thank you.
Administration intubated with angiocatheter cannula as a stent, a simple and inexpensive system.